Hello, I'm Pratima Chowdhury. I work as a consultant hematologist at the Royal Free Hospital, and I'm the chief investigator of the B-AMAZE study. Today, I'll be providing an overview of the B-AMAZE study. The B-AMAZE study is a phase 1-2 study that was investigating the safety and efficacy of FLT180A in its ability to normalize the factor IX level between 50 and 150%. The key inclusion criteria for the study were hemophilia B with a factor level of 2% or less than 2% and an age of more than 18 years. If the patient had neutralizing antibodies to AAV-S3, they were excluded from the study, and similarly, if patients had liver disease, they were also excluded from the study. What about the vector that was used in the study? The vector had a Padua variant of the factor IX gene with a liver-specific promoter, but more importantly, it had a synthetic capsid that was known to be associated with an increased transduction efficiency. And together with the factor IX Padua variant and the increased transduction efficiency, we wanted to see if that would deliver the goal of gene therapy, which is to achieve normal levels of factor IX for this trial. To see what dose of the vector was effective, we used an adaptive dose trial design. In this, we had 4 cohorts. At the lowest cohort, we achieved a level of about between 30 and 50%. Our second cohort had the highest vector dose in the trial, and in this cohort, we had 2 patients dosed not sequentially, but slightly apart. With the first patient developed transaminitis and also had and achieved a final factor IX level that was within the normal range. The second patient also developed a mild transaminitis but achieved a supraphysiological factor IX level, and indeed this was later on associated with thrombosis of an AV fistula. And essentially what this taught us was that this is probably too high a dose. Our third cohort again had 2 patients, and one of the patients in the third cohort achieved a normal level, whereas the other patient was on the way to achieving a normal level but developed 2 episodes of transaminitis, because of which the patient lost expression and is now running around 10%. The other thing we have learned during the period of the study is the importance of the immunosuppression or immunomodulation. We know that transaminitis has a very important effect on the long-term expression. We were also very keen to make sure that we had a predictable dose response in the entire study. So to achieve this, we had a prophylactic immunosuppressive regimen. So in cohort 1, the patient starts steroids around week 6, but from cohort 2 onwards, the patient started steroids from after about 21 days after infusion of the vector. And then through as the trial progressed, we learned that the steroids was not adequate to prevent transaminitis completely, and we introduced a prophylactic strategy with tacrolimus, which was implemented in cohort 4. Cohort 4 included 4 patients. The first patient did not have prophylactic tacrolimus, but the last 3 patients went on to receive prophylactic tacrolimus along with prophylactic steroids. What we found is that the prophylactic steroids and tacrolimus prevented transaminitis, but we did see a mild transaminitis when all immunosuppression was stopped, with some loss of expression of factor IX. If we now look at the final outcomes of the study, as mentioned, the major aim of the study was to establish the safety and identify a dose that could be used in a phase 3 study. If we look at the key safety results, we can say there were no infusion reactions. There was also no evidence of allergic reactions to date. The most common drug-related adverse event was a transient transaminitis. Whilst we were able to control the transaminitis in a rapid fashion, we have seen a transaminitis-related loss of expression of factor IX. Again, I think it brings to the forefront the absolute importance of managing transaminitis in a proactive way as transaminitis has a significant impact on the dose response in gene therapy. A single patient in the highest dose cohort did develop thrombosis of an AV fistula in association with supraphysiological factor IX levels. If we look at in terms of the efficacy, we have seen a stable and durable expression of factor IX in the first cohort, where we have seen levels within the non-severe hemophilia range up to 3 years. None of the bleeds that were seen in the trial required a factor IX supplementation. Most of the bleeds were traumatic bleeds and stopped, and the bleeding essentially stopped within a short period of time. The immune management evolved during the study. Very early on, we used prophylactic steroids, and for the later half of the study, we used both prophylactic steroids along with tacrolimus. A phase 2b/3 clinical trial is due to be initiated in 2021, and the idea is to use a dose that was used in the final cohort with a view to achieving factor IX levels between 50 to 150%. Thank you for your attention.